Okay. That now means that everybody can hear us. I don't know how that happened, but that's okay. Hello, everybody. Y'all can hear us talking now. We're going to get started in 9 minutes. So, and then Julie, if you'll see if we can get you talking. Okay. Hey, Shannon.
Hello, this is Shannon.
Hi, Shannon. This is Mark. We are.
Hi, Mark.
How you doing?
Good, thanks. How about you?
Doing great. We accidentally hit the broadcast button, so we are live now. So we're just gonna hang out for the next few minutes until the webinar. But we'll be handing off the presentations to everybody. I will make you a presenter, and then you'll hand it back to me once you get finished with your presentation. So
that's what I was just going to ask. So I need to pop up my slides now.
Yep, yeah, if you would do that, that would be great. So everybody, we're going to be handing them off to you. If all else fails and it doesn't work, I do have all your slides on here. They just don't look as pretty because when I transferred them over, they sort of got a little bit funky. So
perfect. Okay.
They still look fine, but yours look better. Okay.
Let me get this set up first.
And we're still trying to get Julie to be able to talk.
Oh. Can I get all the other stuff out of my browser?
Elizabeth, did you say something? No.
No, sir, I'm muted.
Okay. I thought I saw your lips move. So I was like, oh, is she talking?
I might have been talking to myself. I was trying to get everything pulled up, so.
Okay. I do that a lot.
Mark, is this one of those share your screen sort of webinars?
Yeah, whenever I get to you, what I'm going to do is I am going to make you a presenter.
Okay.
And then you will be able to get control of it and share your screen. And then once you get it finished, then I will take it back over.
Okay. Perfect. All right. So what I'm going to do then is get everything else off of my screen.
That's a good idea. I had to clean out about 50 different tabs before I start.
Good grief. It's funny.
And
okay. Now I am.
Let's see here.
We're
still waiting on Jonathan to get here and Julie to get back in, hopefully. Cross our fingers.
My daughter's birthday, we were just talking about. Her birthday's March 13. I don't think it was a Friday that day. She was born on a Friday the 13th, but it was the day the school closures started hitting for the pandemic. So you're thinking, man, we're 2 years. You know how much kids have changed in those 2 years.
Yes.
Will she be able to have a real birthday this year?
I'm sorry.
Will she be able to have a real birthday this year with her friends?
I don't. She's pretty small social circle, so she'll probably keep it pretty small anyway.
Mm-hmm.
She's not a 30, 30 over type of girl.
Mm-hmm.
Perfect. Well, it's pretty safe then. She's keeping it small. She's a Pisces.
She must be.
I hear those. I hear their trouble. Those Pisces.
Be nice. I'm a Pisces, but I don't fit most of the things. I'm one of those that's on the edge. So, but be nice now, Mark. So
That's what I hear. I think
you
that's
are
what-
too.
I
Okay.
think I had an evil girlfriend at one time that was a Pisces, so I've always assumed, always associated.
Must be.
Run!
I'm a Pisces too. My birthday is National Margarita Day.
Oh,
So that's
After
not
this-
horrible.
after this session's over, everybody's gonna need some margaritas.
I can see her, but I can't
Julie
hear her.
is back, and Julie is silent again. No. Okay, I don't know why. And Jonathan is here.
How about now?
I hear you, Julie. Yay.
All right.
I apologize, Julie. I have no idea.
It may have been my
Mark and
birthday.
me, we do not get along about half the time. Okay, and Jonathan is here, but Jonathan, we don't have a confirmation of sound for you. There we go. Okay, we're working on his speaker. Jonathan, we've been having problems with some of the speakers here. Julie had an issue making her sound work, so it may be on our end. I'm not sure what's going on. But we are live, so we accidentally hit the broadcast button. Oh, there we go. And Danny, will you make sure that we are recording this session? Because sometimes when that button gets hit before it should be getting hit, it doesn't record like it should.
Yeah, it shows that it's recording.
Okay, all right, so. Okay. Hey, John, can you say just something to us just so we know you can hear, that you can talk?
Yep, I am had to connect through my phone. For some reason, it wouldn't allow me to connect through the computer.
Yeah. Hey, it gave Julie Quinn the same, I don't know if it's exactly the same problem, but it's been acting weird this morning. So what we will do.
I'm just glad you shared a phone number that we can dial in, because one time I was a part of one of these and there was no phone number, and then everybody was running around trying to scramble. So
yeah, that worked out great. We will share the screen whenever we get to it, because I do have all the slides as a precaution just in case something doesn't work, but we will share the screen so you'll be in control of your slides when we do that. So we're going to start up here in 1 minute, and Charles will be going first, then Shannon, then Jonathan, then Julie, then Elizabeth, and then I will finish up with this. So thank you all for doing this. We appreciate that, and it is officially 1 o'clock. So let's go ahead and welcome everybody. We've got 202 of you so far. We have 471 registered. Thank you for registering and attending the RHC update sponsored by North American HMS, Charles James and his group there. So we thank them for the sponsorship of the session here. My name is Mark Lynn. I work with rural health clinics, and there is my contact information. Danny Gilbert is with us as well. She is our partner now with Healthcare Business Specialist. And so Danny will will be taking care of any technical stuff, questions, and she might even say a word or two about cost reports as well at the very end. What we do at Healthcare Business Specialists is we prepare Medicare cost reports this time of year, especially. We do program evaluations, do startups, emergency preparedness, and TennCare quarterly reports if you're in Tennessee. If you're not a member of the Facebook group, we have about 3,300 members in that group. There's a lot of great people in there that answer questions, Charles and James and Elizabeth and Patty Harper and Jeff Harper. And so lots of great consultants that you can ask questions and you can get feedback from your peers, especially in the billing session there where there's a lot of questions about billing. Disclaimer, we try to have everything up to date as of today. And we are being recorded, so if you find an issue with that, please log off now. Questions, there's a question box over here where you can ask your questions. If you want to raise your hand at the end of the session, we can open up the line for you. The slide presentations are on our website at Rural Health Clinic at ruralhealthclinic.com, RHC webinars. We will have a recording of the session at that same location. It'll be on in our YouTube group, our YouTube, what do they call those things? You can subscribe to it on YouTube and you can watch it on there as well. Here is the agenda. Charles James will be our first speaker from North America, just on some billing changes for RHCs. Shannon O'Neill from ChartSpan. There's some great things happening as far as chronic care management, as far as the rates going. So if you haven't implemented that, our friends and partners with ChartSpan, we definitely want you to consider that, because that is a great way to provide a valuable service to your patients, as well as provide a revenue source as well. Jonathan Patenburg from Stroudwater is going to be speaking on, especially your provider-based RHCs, some of the impact of that Consolidated Act from 2020 that increased the independent RHC rates, also had a negative effect on provider-based RHC rates. And so there's he will update you on that. And of course, Julie Quinn from Health Services Associates will talk about crossover bad debts, about what's happened. These rates increase have had a different impact on crossover bad debts. So Julie will talk about that. And then grants management, Elizabeth Burrows. Everybody got this email at the beginning of the week talking about financial management reviews and policies and all of these things. And Elizabeth is going to give us about 10 minutes on that. And we're going to have a full webinar on that coming up. I think it's next week or the week after. We'll have that webinar. I think it's next week as well. And then I will do a very brief update on PRF fund reporting. We're going to have a full webinar on that in a couple of weeks as well. But that's the agenda for today. If you want to go through all 6 of the Lunch and Learn webinars, here is a link where you can skip those, because we'll be doing a lot of billing starting on Thursday. We're trying to get everybody up to speed on RHC billing, especially all the new RHCs that have come about in the last 2 years. It's become something very in vogue. So Charles James with North American is our sponsor. So Charles, you want to tell us a little bit about what North American does, and maybe a little bit about yourself?
Sure. So there's one of my favorite NRHA Policy Institute pictures where I snagged a selfie with HHS. She was secretary, right? Or she was CMS director during the Trump administration, and we get to see her at the Policy Institute, so that's always fun. We're an RHC revenue cycle management company, consulting company. We have hosted billing and EHR. We work off of systems other than our own as well for almost exclusively rural health clinics and FQHCs across the country, and we are in our 30th year. So we do a lot of rural health clinic consulting as well, helped a lot of clinics stand up as rural health clinics. And we also work with Inquidocs and onboard clients using their compliance management service. Our biggest project right now, my biggest project right now, is working on the Rural Advantage. We have put together an accountable care organization for rural health clinics and FQHCs, and we're looking for participants. Come join us. We've got about 6,300 Medicare beneficiaries so we're small in the ACO world, but we hope to be the place that we focus on RHCs in the Rural Advantage. So that's some about North American. And I think I've got the first slot here. So Mark, did you want to add anything else before I dive into?
No, I think let's go ahead. Why don't you go ahead and get started, and I am going to make you the presenter. So that way you can have your slides and have that, and we'll be able to see that.
Excellent.
And you can go ahead and tell us the billing updates.
So we've had a lot happen recently. That's me, you don't care. Remember a while back, we were talking about the physician fee schedule final rule and some of the things that were out on the hospital PPS final rule that affected rural health clinics. And we had some major changes. Perhaps what I consider major is not what everyone else considers major, but what we all, our policy geeks of us, consider major is the fact that our RHC definition of an encounter has changed. It's the first time this has changed, and we got it changed without, not we got it changed, it was changed without having to change the law. So that's actually a big deal. It puts a little crack in the door for what we hope are future modifications to telehealth in general. Right now, so as everyone knows, we've been hoping to get telehealth for all clinical visits just paid like an RHC encounter. We don't have that yet. We do have that for behavioral health visits. So the RHC definition of an encounter has changed to include a mental health visit as a face-to-face encounter using, excuse me, I should say, what constitutes a visit is a mental health visit face-to-face using interactive, real-time audio and video telecommunications. And we do have audio only for this, so that if our telehealth, behavioral health telehealth visit can only be conducted via telephone, or if the patient doesn't consent to using other types of interactive equipment, telephone only visits are considered an encounter. So out there, this language is on the Rural Health Clinic Center website. Use your Googler is the easiest way to find it. It's where this particular guidance is. Beginning January 1, 2022, audio, so I've got my control panel here blocking part of my screen, but RHCs can report and receive payment for, keep getting that, for mental health visits furnished via real-time telecommunications, including audio only. We have to have a 6-month in-person visit prior to our telehealth visit. We have to have an in-person visit at least every 12 months to continue our telehealth behavioral health therapy. There can be exceptions. If we can't get our patient in, there can be exceptions. And we can also allow for more frequent visits as driven by clinical need. So we don't have any restrictions put on this. We have an in-person visit 6 months prior to at least, and then annual visits in person every month, every year thereafter, and we can have an exception. This is brand new guidance. I don't know how you would transmit the exception, I suppose, in the medical record, and then it would really only come up in an audit, but that remains to be seen. We're going to bill these with an 0900 revenue code, just like we would for any in-office behavioral health visit. We're going to bill it with a 95 or a CG modifier, and our 95 modifier is what will indicate that it was an audio and video telehealth communication visit. We'll use FQ for services that were audio only. This, of course, would be restricted 0900. These are our qualified visits for revenue code 0900, and that's what our visits would look. So it's the 95 modifier that distinguishes the audio video, and the FQ that distinguishes audio only. One of our FQHCs did a recent study, and 50% of their patients had access to a smartphone or the internet at home. I have a super hot internet connection. There's almost no place I go. Now that I don't do clinic visits, I've retired from the road largely, but we all know out in rural areas, it can be hard to get a signal, right? So I think it was important that we got that telephone only, and remember the in-person visit exception. The other big thing that we got were a hospice benefit. So not only did we have our encounter definition changed, we had our locations of service changed, so that effective January 1, our physicians can see hospice patients and be elected as the hospice provider. And now look at that, hospice is one of our service locations. It's amazing. So Chapter 9, right out of there, claim processing manual Chapter 9 for FQHC RHC, we're going to put the GV modifier on along with our CG modifier, GV as well as CG for our hospice claims. So we have encounter update, location update. Ooh, I have my descriptions wrong. No, my description's right there. It's just the modifier that would change. So big deal. I think those are big deals. Now, normal telehealth visits remain in effect, so that if it's a non-behavioral health telehealth visit, we still have our G2025. We're still under the public health emergency exception to be a distant site, so that, yes, when the public health emergency goes away, as things stand right now, the G2025 will go away. We're starting to see some pressure and not some pressure, but I think there's some pressure to end the public health emergency at the federal level. And we can see now a point where that may happen. And I think what will happen is we'll get an extension of our G2025 while we figure the rest out, I think is what will end up happening. For right now, 2022, the rate actually went down for our G2025 to $97.24. Remember, it's an aggregate of all the fee-for-service codes. G2025, in this case, we don't have a 0900 code, so modifier 95 is with G2025, so that's going to distinguish it from the behavioral health. It's going to pay at the 97.24. The modifier 95 is optional for these services. Remember, cost sharing is in place. You're going to get 20% of the lesser of 97.24 for your charge. So if you charge $200 for your telehealth visit, coinsurance is still only going to be based on $97. Another big deal at the Medicare level is that PAs can now bill the Medicare program and be paid directly for their services. This is a big deal to our Texas folks. So Medicare now, we had some problems before with PA-owned clinics if there wasn't a medical director there, and that has now been corrected. So that's pretty awesome. And those are my resources. And look at that. I am right at 15 minutes. Talk to me about the Rural Advantage. We'd love to sign you up. It's for rural health clinics. Gotta be a newscaster saying, now Mark, back to you.
Okay, thank you, Charles. That was awesome. And what you said about the PHE ending soon, I know we had meetings on the Hill virtually this week, and a lot of those people were definitely wanting to get get the PHE ended and moving on to something else. So that is great, Charles. Thank you. Our next speaker is Shannon O'Neill. She is the Director of Client Experience at ChartSpan Medical Technologies. ChartSpan has worked with us to help provide chronic care management services to our rural health clinics now for several years, and the rates have increased dramatically. So I wanted to get Shannon on to talk about just the changes there, because I think there's a couple of changes that are very favorable for rural health clinics. So Shannon, I am going to make you the presenter right now, so you are in control of what's being shown.
Perfect. Thank you so much. Okay, let's see. Can you see my screen?
I can.
So glad that worked. Hi, everyone. Thank you so much for having me. I really appreciate the opportunity to talk to you about some of these awesome changes from CMS for RHCs, finally and well overdue. As Mark said, my name is Shannon O'Neill. I'm Director of Client Experience at ChartSpan Medical Technologies. I've been a nurse for about a quarter of a century, but I've worked with ChartSpan for the last 5 years, helping to implement some of these preventative programs in RHCs, FQHCs, hospital systems, provider practices, and clinics across the United States. Our big focus at ChartSpan, as you probably have guessed, is value-based care, trying to change that very reactive healthcare model to more of a proactive, preventative healthcare model. So our big focus, of course, is going to be Medicare-sponsored programs like CCM, chronic care management, or annual wellness visits, or what goes perfectly hand in hand with both of those, quality or MIPS. Just to tell you a little bit more. Today, what I'd like to cover is the TCM, CCM change, which is very, very exciting. And then a little bit more about considerations regarding G0511, as well as the new reimbursement rates for G0511, which are very exciting. So first, and I think, Charles, this really goes hand in hand with some of the discussions that you had. ACOs are really encouraging a lot of the RHCs that we work with to put time into billing for or capturing TCM visits with their patients. And as you know, CMS, when they made the rule change for all other practices in 2019, did not carry that awesome rule over, ensuring that TCM and CCM were not a billing conflict for the RHCs. So that hit really hard as you were trying to capture those codes, and then making sure that there was no billing conflict between the TCM services provided and those valuable CCM services provided. It created a little bit of an issue going back and forth to make sure that that was not going to be a problem, but that's gone. And now for folks like Charles and his organization, you can capture those TCM visits, provide those care gaps, and close the loop on those services, as well as for CCM. So this is another really neat thing that CMS has done, and I think there are positives to this and negatives to this. Now for G0511, that's created basically an umbrella for many of the services that were already provided at the organizational level. So you have, of course, CCM, our bread and butter, and then you also have PCM, and then BHI. So what had happened was we were billing each of those at different rates. CMS has looked at all of those rates and decided to put all of those services under one code, one HCPCS code, G0511, and provide basically what they think is an average reimbursement for all of those services. So the positive would be if you're an organization like many these days that is understaffed yet would like to provide some valuable service and support to their needy patients, you now have the capability to choose what sort of service you provide. And in some cases, maybe you would have received a little bit less of a reimbursement or a little bit more. Now you have that capability of billing G0511, capturing that reimbursement while providing that extra resource and support for your patients. And that's nice because you get to choose which sort of service you want to provide. You know, PCM only requires one chronic condition, and it's a little bit more short or temporarily provided in terms of service typically. CCM, of course, long-term, easy to provide if you have a service like ChartScan. And then BHI is so necessary these days with patients, just to ensure that they're being taken care of at home, that they're getting the support that they need in order to maintain compliance with their treatment. So this is kind of a good change in that way, but if you are the type of practice that is few and far between, where you had multiple resources to capture a couple of these different codes previously, and then bill for these different codes and receive reimbursement for them, then this may not be such a positive change for you. But I would say for the majority, this has been a very positive change for the clinics and organizations that we work with. So a little bit more CCM. So CCM, of course, we talked about before, it's one of ChartScan's main focuses in terms of the products that we offer and support we offer to patients. We have probably 40% of our client base as an RHC or an FQHC client. So it's very near and dear to our heart to work with these patients and help support them between providers visits. The types of support that we provide in CCM are going to be things like transportation assistance, Meals on Wheels assistance, coordination with local resources. We do assessments and learn a little bit more about what's going on with the patient in terms of their non-physiological factors that may affect their health compliance. So for us, CCM is an easy way to capture that $81, and I skipped to the next slide, that $81 reimbursement rate. So jumping ahead a little bit, CCM, one of the wonderful things that this new rule has provided for us is in terms of CCM and then also BHI and PCM, it has increased the rate for that billable service by about $16 per patient per month. So that's kind of a huge hike. If you were a patient who was receiving this service and then you also needed additional services, I know that that's a little bit of a leap, but and to be fair, the $16.07 increase in the reimbursement is approximately the cost of the cost share for the service provided as well. But we feel like this is going to be such a benefit to practices who are struggling to provide that added support for their patients. There is a website, a tool that you can use to determine what sort of reimbursement this code would provide you in your area. And we can share that with you. I think actually Mark is sharing that with everyone on the call just to make sure that you have that added resources, just to know what's available to you in terms of that support. And really, that's all for me. I'm going to kick it back over to Jonathan now.
Okay, I made Jonathan the presenter, and so Jonathan Patenburg comes to us from Stroudwater. I must say, Jonathan has a very good selection of places to live. He in Hawaii and Maine, absolutely two of my favorite places in the whole wide world. And besides having an excellent choice of places to live, he really does well with this very high level, very complex work with provider-based rural health clinics with cause, with different types of providers from a legislative standpoint. So Jonathan, you should have control of the slides right now, and I'll turn it over to you.
Thank you very much, Mark, and I appreciate the opportunity to present some of this information today. Hopefully everybody can see my screen if you just want to confirm. All right, thumbs up. So as Mark had said, you know, there's a lot of complex information that goes into dictating how this ends up impacting the organizations going forward. A little background about me, principal at Stroudwater Associates, been here with the firm for about 6 years. And in that time, I've predominantly over the past 4 years worked with your rural health clinics, mostly around the provider-based setting. So really looking at how we could leverage those opportunities to expand access to and ensure the solvency of service delivery within rural communities. In addition to rural health clinics, also focus predominantly on critical access hospitals and looking at all of those other things. Now, as I'm sure everybody is aware by now, as a part of the Consolidated Appropriations Act of 2021, there was a material change in the RHC reimbursement going forward. And what it did is it changed reimbursements for all RHCs, and there's several different ways that it has done that. For our independent and our greater than 50-bed hospitals, it ended up increasing the reimbursement rate, that upper payment limit going forward. And again, that rate was artificially low. It was much lower than it should have been for decades. So I really applaud the organizations that pushed to increase that independent rate. Now, when we talk about the methodology change for an independent perspective, there's not really a change to the reimbursement methodology. What changed is the rate itself from an upper payment limit perspective. So in 2021, on April 1st, that rate went up to $100 as an upper payment limit, and it's trending forward to $190 in 2028. And again, that'll put it near on par with what our FQHCs are getting from an all-inclusive rate perspective. So again, much has gone forth to increasing that rate going forward. For our provider-based rural health clinics that were owned and operated by hospitals with fewer than 50 beds, they actually saw a change in the reimbursement methodology. So they went from going a truly cost-based reimbursed organization to being subject now to an upper payment limit going forward. And depending upon when that rural health clinic was established, will ultimately dictate the reimbursement rate they get going forward. Now, MedPAC came up with this neat little graphic, and Mark actually shared this with me, and I recreated it for the presentation today. And it really does a good job of putting a visual representation of how organizations will be reimbursed going forward. Now, after I talk through this for a moment, we will get into specific examples of how organizations will be impacted relative to their reimbursements going forward. Again, some positive, and as Mark had alluded to, some negative. And what it does is it highlights the importance of why we need to start looking at the ability to improve efficiencies, to increase the number of visits around our minimum productivity thresholds, and all of those different factors. So when we look at our rural health clinics, again, it's broken down between really our independent rural health clinics and our provider-based rural health clinics. Now, our independent rural health clinics, there was really no change again in the methodology. What happened is the rate increased from an upper payment limit perspective. So if we look at that on the picture right here, that's why it jumps all the way from that top left all the way across to the right. They are capped at that national limit from an upper payment limit perspective. Now, if you're a provider-based rural health clinic and you are owned and operated by a hospital with 50 plus beds, again, you are subject to that same capped rate, the same as before. The difference is that upper payment limit is increasing from that $100 to $190 through 2028. Now, where it really gets interesting is for our rural health clinics that are owned and operated by organizations, hospitals with fewer than 50 beds, those that are actually established as provider-based according to 41365 and looking at it from that perspective. Now, the biggest change for these organizations is the creation of a grandfathering provision. Now, RHCs that enroll in Medicare after 12/31/2020 or applied to be a rural health clinic after that 12/31/2020 are all subject to that upper payment limit. Rural health clinics that were enrolled before that 12/31/2020 or had applied to become an RHC prior to that date will have a grandfathered upper payment limit. So if your cost-based rate on your 2020 cost report was, say, $200, that'll be that starting upper payment limit for that clinic that'll then be trended forward for that organization. Now, this all sounds great in practice and all that, but what does this actually mean for organizations going forward? Everybody wants to know, how does this impact my reimbursements? So if we look at it going forward for our independents, let's assume, and across the next three models, all of these are 10,000 visit rural health clinics and they all have 35% or 3,500 visits of Medicare. Now, the reason I'm only looking at Medicare is I don't want to get into the nuances of some states are cost-based for Medicaid, some are not, Medicare Advantage, so just Medicare perspective. Now, if we look at it from this perspective going forward, what we looked at in that first visual representation is, first we looked at the prior capped RHC rate, that upper payment limit in the past. And in 2020, it was 86.31, then went to 87.52. What I said is, going forward, let's assume that that rate was increased based on the Medicare Economic Index, and let's just say 1.5%. So that's where you see it just going up that 1.5%. Now, let's assume that that clinic had a cost-based rate of $125. Now, under the prior methodology, they would have been capped in 2021 at 87.52. Under the new methodology, they're going to get that $100 payment because, again, we went up from the 87 to 100. So they're going to gain roughly $12.50 per clinic visit. Now, if we assume a 3% annual cost increase, we increase their cost-based rate each year by 3%, we can see out in 2025, the actual rate that they're going to receive is that $144.91. And the reason for that is because as a rural health clinic, you get the lesser of your cost-based rate or that upper payment limit. So for this clinic, the first 4 years, they're going to see a great increase by going up to that upper payment limit. And then eventually in 2025, they will be subject to their cost-based rate. So what does this mean over the next 8 years for this clinic? Now in 2021, they would have gained about $43,000. I would love to have an additional $43,000. I'm sure everybody on here would. Going out to 2028, even though they're not going to get that $190 upper payment limit, they're still going to get a cost-based reimbursement of $158 versus what may have been $97, $98 in the past. So they're still going to gain $61 a visit, $214,000. Now this will go a long way towards sustaining the solvency of our independent rural health clinics, our greater than 50-bed rural health clinics. It'll go a long way to improving access, the ability to increase care. Now, on the inverse of this, as we talked about the grandfathering provision, we looked at the same exact clinic. So assume the same 10,000 visits, the same reimbursement, or the same cost increases. Now, because of the overhead step down to these clinics, this clinic had a cost-based rate of $175. Not getting into all that, Mark can explain it probably much better, the nuances of cost report methodology, and you punch a bunch of numbers in and it spits out something great. But this clinic had a $175 rate. If we increased it by the same 3%, we would see that their cost would go up from $175 to $222 over that same 8-year period. But as you remember in the law that was passed, they are subject to the Medicare Economic Index increase. So we would take their $175 rate and increase it by that 1.5% each year going forward. So every single year, if this clinic sees a 3% cost increase and the MEI is capped at 1.5%, they're going to lose 1.5% reimbursement from Medicare each year going forward. And we can see that that equals about $9,000 in 2021 versus $86,000 in 2028. Now, what does this mean for organizations going forward? It doesn't mean get rid of your rural health clinics by any means. What it means is that we need to increase efficiencies. We need to focus on throughput. We need to focus on the CCM, the TCM, like other people were mentioning, like Charles was mentioning around the behavioral health. We need to focus on those services. We need to look at additional ways that we can control our costs going forward. And it's really going to ensure that we operate but control those costs going forward. Now, there will be environments where we can't control our costs, but it's important that we know as organizations that we do have that upper payment limit cap going forward. Now, just to show one more model before I wrap up real quick, what I also looked at is a perspective of a variable cost increase. no organization is going to see a 3% increase year over year over year. One year it may be 1%, one year it may be 3%. So what this organization shows right here, again, same exact clinic, but what I did is I changed the increase from a cost perspective each year and said what would happen to that organization if some years we're able to control our costs and some years we had higher costs. So we can see that in the first couple of years, there's not much of an impact over the first 3 years if we can control our cost relative to that position. But if we look at 2024, if we have 1 year where we have a cost that jumps up, say 3%, it will take us 3 years to recover that amount at a 1% cost increase. So again, we really have to start tracking the data, the performance. Gone are the days for our provider-based rural health clinics where we could really look at it and then say, we're just going to get cost-based reimbursement, so it really doesn't matter. I'm going to turn it back over to Mark now. I know I've shared a ton of information at a very high level, but I really wanted to just increase some awareness around these complex topics.
Thank you, Jonathan. I actually understood that. That was great. It was, you made very complex information. Let's see here. Whoopsie. I'm changing. There we go. Now I'm going to make Julie Quinn the speaker now. We all know Julie. She is the Vice President of Compliance and Cost Reporting with HSA. She works on cost reports all the time. She worked with Riverbend back in the day. Julie's been doing this now for 25 years or so, and she does a fantastic job. So Julie, take it away.
All right. Can everyone see my screen? Yes, good. Bad debts. All right, so I am going to talk to you more from Jonathan, thank you for your explanation. I am going to dumb it down a little bit and just get kind of really down in the weeds here for a second. And also you will see my trademark Minnie Mouse cup come out just to be sure that I can speak properly today. All right, bad debts under the new payment caps. This is something I called Mark about a week ago. We were just kind of talking for a minute, and I said, have you talked to anyone? Have you heard about some of these new implications? He said, well, okay, let's just throw you in here. 5 minutes. We're just going to talk about why it might not have been important to you before, but it is probably going to become important to you now. This is more for our independents, provider-based that Jonathan was just talking about, that have had the higher rates before this moment, probably won't see as much of an impact. First of all, let's just go back to the basics. Again, why is it different now? As your rate increases, these bad debt becomes more important. So if you have never looked at bad debt before, I want you to take a look at it this year. I want you to continue to watch it as this rate goes up. But first of all, what is it? All right, Medicare bad debt is unpaid Part A deductibles and coinsurance, and it's paid at 65% on the Medicare cost report. I always like to go back. I get a lot of questions saying, well, can I count this? Can I count that? Is it this? Is it that? And my example always is, if you can't tie it to a Part A, Rural Health Clinic Part A, paid claim, deductibles, or coinsurance, it doesn't go on this log. It is unpaid deductibles and coinsurance on a regular red, white, and blue card Medicare remittance advice. So we're starting there. Always start there. If you have tried to collect on it and you cannot get paid, we write it off to this bad debt log. But when do we write it off? It is important to note that this bad debt log is based on date of write-off. You log it, you put it on the log in the year you wrote it off. So you could have 3-year-old dates of service on there if you've really been trying to collect. So only Medicare Part A, deductibles and coinsurance. It goes on the log when you write it off. It most often does contain dates of service for prior periods. It is based on date of write-off, not date of service. Those are, again, we're just sitting in the basics right now. I like to talk about two types of Medicare bad debt. The can pay but won't pay, and the can't pay. Can pay but won't, you have to make collection efforts minimum of 120 days, same as any other collection efforts. Can pay but won't. But for today, the 5 minutes that we're just going to talk about, we're going to talk about the can't pay, the indigent patients that you've crossed over to Medicaid, and why that is now important. So the can pay and the can't pay on Medicaid. If they're indigent, they can't pay. You cross that claim over, you must bill Medicaid as proof of eligibility. You must have a processed state Medicaid remittance advice. And then once you have that paid claim, you can take any remaining balance straight onto that bad debt log. For your non-indigent patients, you have to do reasonable collection effort, same effort, minimum of 120 days. That has not changed. The significance of that has not changed. What has changed, why it matters now, is because when you cross that claim over to Medicaid, a lot of our states, especially our independent clinics, they've had their Medicaid rate has been hovering just above what the Medicare rate was. So let's just go through this example. How example assumes clinic's Medicaid rate is $100 above the old cap. This is the old way. Medicare back in 2019, they paid 80% of the rate, $69.05, leaving you with a nice coinsurance there of about $17. You cross that claim over, Medicaid looks and says, well, Medicare paid you $69, you have $17, we'll pay that co. We're actually going to pay you, make you whole up to your Medicaid rate. So they're going to make a payment. So on this law, on this particular person, Medicare paid $69.05. Medicaid paid their coinsurance. There's nothing left. There's no balance left. No need to write off bad debts. And that's why a lot of our clinics have never even looked at bad debt, because they looked at it a while back. None of their claims applied because Medicaid picked it up. Medicaid picked up everything. And it was too hard to go through the audits of the non-indigent patients. They didn't want to fool with that. But this is easy money if you've got a Medicare paid, Medicaid paid, and you write off the balance. But before now, there just wasn't a balance left. So let's look at that in today's world. Let's go, I kind of went out of it to just kind of show the effect where we're going to be next year at 126. Same Medicaid rate. You're in a state, your Medicaid rate is $100. Next year, the Medicare rate is going to be capped at 126. And if you're, as Jonathan explained, if your cost is above that, you're going to get the lesser of the cap or your cost. Cap's now 126. So on that particular claim, Medicare is going to pay 80% of the rate, $100. Okay? You cross that claim over to Medicaid. Medicaid says, wait, your rate with us is $100. You've already been paid over $100. We're not paying that coinsurance. You're whole. You've been made whole. So now you can take that unpaid coinsurance straight to the bad debt log and get paid at 65% of that. How this came up for me is I was talking to a Texas clinic. We were getting ready to prep this year's cost reports. I was walking them through our packet, and the doctor was like, well, why have we never done this before? We actually pulled out some remittance advices. And because he was getting ready to get mad at his office staff, like, why, ladies, why have you never looked at this? Why not? Well, when we pulled it out, it didn't matter before, because Medicaid rate was up here and picked up the coinsurance. There was nothing left. Medicare paid, Medicaid picked up the coinsurance. There was nothing left to write off. But as we get into these higher rates, depending on where your Medicaid rate sits, when your Medicaid rate starts dropping below your Medicare rate, then there's going to be balances left after you cross that claim over. And be sure you're not leaving money on the table. If Medicare pays, you cross it over to Medicaid, they pay or don't pay anything. Whatever's left immediately goes to that bad debt log. It's an easy claim. All you have to be sure you keep a hold of that Medicaid and Medicare remittance advice. That's your documentation. That's it. And get paid. Don't leave money on the table. Fill your piggy banks.
Okay. Thank you, Julie. That was awesome. That's a good reminder. When you called me the other day, I haven't even thought about that. And then it's like, oh yeah, I did the math on it. And it's like, oh yeah, that's like $5 or $6 more every claim, and you get 65% of that. That starts adding up to real money if you keep up with it. So, so absolutely, that is a great idea. Okay, let me see here. Elizabeth, I am going to make you the presenter now, and Elizabeth Burrows, she's a lawyer from Indiana. She knows everything about grants and about FQHCs and all that, and she's been a great friend with RHCs. So Elizabeth, take it over and tell us about RHC grant management, please.
All right, thank you, Mark. As Mark alluded, many of you received an email, which led to Mark and myself, and I'm sure some others on the call who got additional emails forward saying, oh no, what do I do about this financial management review? So we're going to do some short answers to that question. Today is kind of the Cliff's Notes version answers, and then there is going to be a lunch and learn next week to get additional details. So first, making sure with your RHC grants management that you're actually in payment management system and drawing down funds. I have had a few of you call me saying, why hasn't the money been put in my account? Or people have even said, I've already spent the money, so it was in my account, right? I already spent it. No, it is not in your account. So make sure you're set up with payment management system, you're regularly drawing down the funds, and make sure the money is flowing to you. In other words, follow the yellow brick road to get your money. Make sure you're following those proper steps. Make sure even if you went in payment management system and drew it down, that the money actually went in the proper account. My team and I have been working with some people that had actually went in a different account. They forgot they registered a separate bank account. So make sure you know where those funds are. Next, have you tracked how you spent your funds? Make sure that you are keeping at a minimum some kind of an Excel sheet that shows how you are spending that money. The $49,000 and change per clinic. For some of you, this even was 6- and 7-figure awards for those of you that have multiple clinics. So make sure you are properly tracking those. And then, are you submitting your FFR reports? Many of you, I think, got notices that they were late or they weren't submitted properly. So make sure you are doing that, and you've set up a quarterly reminder for yourself to log in and do that. And then just a reminder, making sure you are using these grants to effectively promote your rural health clinic. This is your chance to get the word out about the awesome services that you provide. I believe in rural health clinics and FQHCs and what they do. And I know you guys deserve every chance to keep up with the big dogs. So we want you to be able to effectively promote your clinic. So here are a couple examples of some clinics that I'm aware of. We have a billboard that I thought was really nice. And then also some people using cars and things like that. Make sure, billboards, health education, promotional materials, hopefully the money that you have will then lead to you getting more money because you're going to get more patients in the door. People are more aware of the clinic and the services you provide. And so hopefully this $49,000 will actually lead to additional revenue from the visit income that we've been talking about on this call. Now, what is a financial management review? It is not Scrooge McDuck diving through all of your financial records. It is not a financial audit. So first of all, take a deep breath. All FQHCs, all grantees, if you've ever received an Office of Rural Health Policy grant, a SAMHSA grant, or some other grant, you have probably been through this, and everyone has survived. It is a virtual review, meaning that you will be asked for documents and you will provide those documents. Overall, it really is just a review of your policies and procedures. Make sure you respond to emails and HRSA correspondence. I could say this 10 times, and I just want to make sure you respond to all emails and HRSA correspondence. Check your spam folders, trash folders, check your pop-up blockers. Make sure that you are getting all of your emails and you're responding to those in a timely fashion. Oftentimes they do come from an @HRSA.gov, but sometimes HRSA does contract those out. This is an active process and you are expected to respond to HRSA's requests and make any revisions as appropriate. I will tell you, as we know with RHC reviewers, not every financial management reviewer is the same. So there is leeway in how these reviewers interpret policies and changes that they want made. What policies do you need? You need to have policies on these things. Cash management specific to your grant and how you track that. Your accounting system and how it works. And that does not mean that I have an accounting system. I use QuickBooks and I have the QuickBooks manual. No, you actually need policies on how things are entered in your system and followed up on in your system. Disbursements and procurement. Procurement is a big deal, especially if you are spending a sizable amount. If you just have a $49,000 grant and you're not buying anything that costs, say, over $5,000 or $10,000, it's probably not a big deal. But if you are entering a large contract, that is a very big deal. Timekeeping and how you're allocating proper time for the people being paid by grants, and the allowability of costs. So again, when we say allowability of costs, this is not necessarily what Mark and Danny say is allowable on your cost report, but rather what is allowable to be spent with your grant. And I know many of you have been on workshops with me before, and I think you've heard me say, always read your NOA or your notice of award that says your amount of money. But I encourage you, for everyone on here that received a grant, pull yours out, have it printed the old-fashioned way, and actually look at your NOA to make sure you're doing everything that you should be doing. We are going to be doing a lunch and learn with a much more in-depth about what policies you need and what those policies need to entail. Also, in the email that you received, there are links to HRSA's resources and sample policies on that. So I encourage you to click into those links and look at that before our webinar, where we're going to go through more in depth on exactly what is required of your financial management review. And also, this is just a side note, but USDA rural emergency healthcare grants are still available. Many states got extra money, so there was more money there than originally thought. The October deadline for Track 2 has came and gone, but Track 1 is still open in every state that I am aware of. So every state is still taking those applications, and they have to spend the money by this fall, the end of the federal fiscal year. So if you have a capital item, if you want a mobile clinic, if you want any sort of supplies, especially anything that is not a building, because buildings do take a lot more time for USDA to approve. But if you need equipment to go in the building, medical equipment, office equipment, furniture, anything like that, any kind of mobile clinics, mobile units, anything that you can think of that can be related in some way to COVID-19, please take advantage of that. Contact your USDA office, contact me. I'm glad to assist. But we want to make sure that rural America takes advantage of this unique funding opportunity. So thank you, Mark, for this opportunity, and I hope to see a lot of you next week where we can dive into these financial management reviews.
Oh boy, that sounds so exciting, Elizabeth. But
I mean, I really know how to get excited, how to tell you.
We're going to be overwhelmed. I don't know. We only can hold 1,000 people in one of these webinars. I'm not sure if we'll be able to get them all in here. So, no, I am teasing. Thank you, Elizabeth. We appreciate you. We would oh my goodness, these grants management, everybody's talking about how much work this is. So we appreciate having you to guide us through grants management. Otherwise, this group would be lost. Let me tell you. I know I would be. So oh, let me see here. I went through the wrong. Let me go to where I'm going to be talking. Let me see. Here we go. I'm going to talk just a few minutes on provider relief funds, just to ease your mind, because a lot of you are sort of really worried about provider relief funds, what we have to do for period 2. Period 2 covers the period July 1, 2020 through December 31st, 2020. If you receive payments, $10,000 or more during that period of time, that's what you're going to be reporting on, and that is due by March 31, 2022. The good news, or maybe it's the bad news, is most of the independent RHCs that we work with did not get over $10,000. Some of you got a few $1,000s, maybe $3,000 or $4,000. We actually do about 50 PRF fund reports for our clients, and of the 50 so far, only 2, from what we've looked at, 2 out of 50 have had to actually report some additional information here. What you do need to do is go into the portal and just basically you have to change your password and let them know that you were there, and basically just agree with them that yes, we didn't receive any funds during that period of time. It should take you less than 5 minutes to get your period 2 provider relief fund report done. So here's just some resources for this. Here's what your portal looks like. You'll go in, like I said, you'll enter in your login information here. You'll change out your password to a 15-digit number. You'll click here where it says report 2, and you'll go over your information, make sure that it is accurate, and hit save and next. And then you're going to tell everybody that you don't have subsidiaries. If you're a big hospital, you'll be answering yes to this if you have a bunch of subsidiaries as part of your tax ID or whatever. But for most of our independent RHCs, these 2 answers are going to be no. And you're going to, you'll get a listing here. This is an actual one where it shows what funds we received during period 2. And you can see we didn't receive any. So we're going to answer yes, that's correct, and move on to the next one, and we are finished. So I'm going to say less than 5 minutes for most of our independent RHCs that we work with. It's not that big a deal for period 2. Now, it will get a little bit more complicated going on when you've got period 3 and phase 3, phase 4 funding from PRF funds. If you get those in later periods, then it will get a little bit more complicated. If you are one of these, this clinic here actually did receive $206,000 during this period of time. We're going to have to go in and fill in. We filled in the information for these previous quarters for most of them, but you have to fill in your quarter 3 and your quarter 4 information here. Same thing over here with your expenditures. How much you spent on COVID expenses, you're going to have to put this in quarter 3 and quarter 4 of 2021 as well. Same information you were gathering before is what you're going to have to put in these PRF funds. And then for your 3rd and 4th quarter of 2021, your actual collections by payer is what you're going to have to put in here as well. So those are not hard at all. Your metrics, you're going to have to give an updated information on your metrics. How many full-time employees, part-time, contractor, furloughed, separated, and hired that you have. And then you have to put in these number of patient encounters as well as an independent RHC. This is only if you received additional monies during this quarter is when it asks you to provide this information. It's $10,000 or more. Like I said, most of you will not have to do this. Just a very quick reminder too, we are part of the No Surprises Act is in place right now. It's sort of going to, as of right now, you're required to, GFEs are required. That's called a good faith estimate. You are not required to do coordinated care estimates, which means if somebody is getting lab and x-rays and getting surgery somewhere else, you don't have to make those estimates as of now. Actually, the law is effective, but they're not going to enforce it to 2023, January of 2023, thank goodness. Your estimates have to be within $400 for most rural health clinics. That's not going to be a problem. We don't really charge that much in most cases, so your estimate has to be within $400. Who do you do it for? Anyone scheduling an appointment 3 days or more out. So if you're sort of urgent care and somebody calls you and they come the next day, this GFE is not required. So you probably want to try to get as many of your appointments within the 3 days that you can possibly can, so you don't have to be responsible for getting these GFEs, because the template that they give you is 10 pages long. It's very complicated. What you're gonna have to do is it has to be electronic or written. It's gonna be a nightmare. Let me just tell you, this is a lot of work for your receptionists. They're gonna be the ones that have to ask this question, which is a crazy question. Do you wish to submit a claim to your insurance company or something like that, where this is only for uninsured people, self-pay, or people that don't plan on using their health insurance to pay for their health, which, I mean, who would do that? But I guess there is some people out there. The best way to do this is to work with the Azaleas of the world. They're one of our partners, and Charles's group as well. They've got a billing system as well. It's going to have to be built into your electronic health record, I believe, the way to get this thing done logically. Otherwise, you're just going to be in a sea of paper. And so I would talk to your electronic health records people, see what type of GFE they have built into their system, and because your receptionists are going to be underwater with dealing with this going forward, and they're going to need a lot of training on how to deal with this. So that's really all I wanted to say. What I would do is go back and listen to this webinar. Bill Fennerfrock and Nathan Baugh did a great job explaining this in December. So go back and listen to this webinar. I've listened to it for a couple times, and I keep getting more and more frustrated with these rules. It is crazy. So what I did was I actually, here's some of the stuff that the NARHC put together. They actually put in a question and answer FAQ from that webinar. Download that. That's going to be extremely helpful to you. This is a part of it where it gives you of what you need to do as far as getting GFEs out, as far as what the time frames are. And then they also give you a link to all the downloads that the government is expecting you to do. This is each one of these is 10 to 25 pages long. Print these things out. You're supposed to be posting these in your lobby and posting these on your website. When I looked through this, I was like, my goodness, there's so much information in here. How in the world is any patient ever going to read any of this information? You need to get policies and procedures together for this. We don't have a resource yet that does that. Probably if you're using Inquidocs, that's probably your best bet, because Patty Harper and Jeff Harper, I am no doubt, are working on putting something together that will make this work for you guys. But the law as it's written now, it just seems like it's caused more problems than it's solved. And unfortunately, the government has a way of solving a problem that exists. You know, surprise billing is a bad thing, but their solution really didn't solve surprise billing. It just made another problem that we did not have. So that was just a quick update. And this is a great thing too from the NARHC. They put together this flow chart on when you need this. This is a part of those FAQs that the NARHC put out. So I would get that and study this. I'm not going to go through it right now because you've been here for an hour and 5 minutes and your brain is probably shot at this point. But I just wanted to give you some quick reminders on PRF reporting. I wouldn't worry too much about that. If you're an independent RHC for period 2, it's going to be easy. And then the exact opposite on the GFEs and the No Surprise Act is spend a little time on that, get something in place for it. I don't think it's going to have this big effect on what you what actually happens, but it's going to have an effect on what you actually have to do and document that you're in compliance with it. So I think that's everything we have. Danny, do we have some questions in the questions box?
Yes, sir. I have one for just about all of you. Charles, we'll go to yours, back up to yours first. The mental health visits must be with an LCSW. Is that correct?
Or a clinical psychologist, or it could certainly be a psychiatric nurse practitioner, but yes, the language talks about these are really therapy, behavioral health therapy services by clinical psychologists and LCSW. And for the moment, the licensed professional counselors and the master's level folks are not eligible for Medicare visits.
Okay.
So check your state. Many of our states have changed those behavioral health providers to expand those definitions. Indiana certainly has, Illinois has. I don't think Missouri has, but many have. So check your state if you have an LPC on staff.
Thank you. Shannon, we're going to go to you next. Let me try to read through this. So if they have availability and 2 chronic illnesses that our providers care for with our patients, we can bill this once a month. And what kind of documentation do you need to back it? Or is this a visit code we charge? We change.
For a G0511, what you would need, did not specify. Okay, so assuming G0511, which is a big focus of the slides that I shared, it depends. So for behavioral health, there are specific eligibility requirements that allow you to bill less than the collaborative care that Charles is referring to. And then for PCM, the patient only needs 1 chronic condition. They can be billed by the provider for 30 minutes of time spent. For CCM, which is probably the easiest to achieve, the patient does need to have 2 chronic conditions. The billable time is 20 minutes of time spent on care coordination for the patient. And again, that's telephonic in nature. Ideally with CCM, the care is provided by an alternate service, so it doesn't take up very many resources on site for you, like a turnkey service like ChartSpan offers. If you were doing it yourself on site, you would look for patients who have those 2 chronic conditions, Medicare Advantage, and have seen the consenting provider in the last 12 months to qualify. But then you will need to enroll those patients either verbally with a verbal consent or a written consent, store that information in your EMR, and then you would spend 20 minutes of time coordinating their care. So that can be anything from arranging prescription drug refills, doing assessments with those patients, providing updates to or supporting the treatment plan that the provider has already in place for that patient's care, and then documenting that information in your EMR. Some EMRs allow you to time the information as well. I know ECW has a CCM module that allows you to time the efforts spent on managing care coordination for that patient. But there is a little bit of work if you're doing it yourself, because you're identifying patients yourself, you're consenting patients yourself, and then you're also reaching out and then documenting on those patients yourself in order to maintain compliance.
Thank you. Jonathan, you're off the hook. You don't have any questions. Julie, does this only apply to patients that have a Medicaid number as the secondary? I'm sorry, I'm just learning billing and want to make sure I understand.
So there are 2 types of bad debt. There is the can pay, but won't, because you've tried to do the collection. And then there's the can't pay. Now, usually when we're and that's what we call the indigent category. Usually that's Medicaid, dual eligible Medicaid patients. There are other ways to document indigence, way more detailed than what we want to get into here today, but it's complete financial records. Can't be a note from Ms. Smith that says I can't pay. It really has to dig in. So it's not just Medicaid. that can go on this bad debt log. You either tried to collect it and they couldn't get them to pay right off the balance, or you crossed it over, Medicaid paid you right off the balance, or they were just indigent by other means. I'm just very hesitant with that because it's hard to document in an audit. It's hard to get through those audits. So there are other categories that go on this bad debt log. But the one we see most of our clinics focus on is the crossover, because it's the easy, it's the low hanging fruit, it's the easy money. If you cross it over and there's a balance of the, remember we're starting deductibles and coinsurance. Medicare pays, leaves a co-insurance, Medicaid pays. If there's a balance left, don't leave that money on the table. Write it off the patient's account and put it on the Medicare bad debt log.
Yeah, and Danny, you should have two different logs. You should have your Medicare log, which are patients that don't have Medicaid, and then you should have another bad debt log, which is your Medicare/Medicaid crossover dual eligible log, and keep those in two different logs because, like Julie said, there's the Medicaid crossover log. You're not going to have a time frame of having to wait 120 days, and you're not going to have collection efforts for most of your Medicaid folks there. While your Medicare only log, you are going to be required to try to make collection efforts for at least 120 days and do everything that you need to for bad debts. I think Julie talked about having maybe a full session just on bad debts as a lunch and learn. So we will get around to scheduling that when both of us can do that. That would be great. So okay, Danny, next question.
Okay, Elizabeth, I know you answered this in the chat, but just in case other people needed to hear the answer as well. For track 2, does that still apply only to RHCs that are nonprofit?
Yes, just for clarification, track 2 is closed. It would be track 1 that is still open. That's up to $1 million per entity. And yes, you have to be nonprofit. So again, keep in mind there are ways around that, but again, the equipment, the vehicle, the building has to be owned by a nonprofit. So thank you.
Okay. I've got some more CCM questions. Mark, I don't know how long we've got. There's quite a few. So
we'll go a few more minutes.
Okay.
I may have to hop off, but thank you very much. And I will see you guys next week on our lunch and learn.
Thank you, Elizabeth. We appreciate you.
Okay. Back to Shannon. Can CCM or PCM be billed if doing anti-coag warfarin management?
That's a very good question. I will have to look into that and get back to you. So are you referring to following patients for non-physiologic, like remote patient monitoring, but for non-physiologic factors, focusing on more medicine? Your cat jumped in your lap, Mark.
Yeah.
If you're focusing more on the non-physiologic factors, that's a different code entirely, actually. So, and I think that's still in the works. Maybe Mark, you can correct me if I'm wrong.
I'm not sure. That's billing is one of my weakest points, especially the new stuff there. I know remote monitoring is a very difficult thing to do with rural health clinics. I think some people have figured out how to do it, but I'm not one of those people yet. Charles, have you remote monitoring? Is there a way to do that? I'm not sure.
I believe that no.
Okay.
We excluded because if you look at the G0071, it's one of those aggregate codes, and it does not include remote patient monitoring on that G0071 code. And I think that would be our only option to bill it, though I haven't found any place to say it's specifically excluded from RHC. I know it's not included in that virtual communication service for us.
Yeah.
For CCM, though, if your patient did have a chronic condition that led to the requirement for anticoagulation monitoring, certainly that would qualify the patient as long as they had a second chronic condition code, and then you could create protocols for CCM services around any specific disease process to ensure that those things were managed and reported on. So I guess in a way, yes, you could bill G0511 for monitoring of anticoagulant services for that purpose as an RHC.
And then think about that just exactly in terms of like a diabetic counselor, diabetic RN. You can't get the line item from her service on a rural health clinic claim, but certainly that clinical activity would count towards their care management plan, right?
Absolutely.
And certainly that clinical activity is going to count to our quality measures. So remote patient monitoring is a little more difficult because you have equipment involved, but sometimes the line item is only one of the reimbursement considerations.
Very well put. Thank you, Charles.
Well, Danny, I think we've got it 2:16 Eastern time. We've got an hour and 16 minutes. We probably ought to close it down, so respect the time of our panelists and speakers and everybody. So thank you to Charles, to Shannon, to Jonathan, to Julie, to Elizabeth, to Danny. We appreciate you guys, and we also appreciate what you guys are doing out in the field there. Stay safe. Thank you to everybody, and we will see you. A lot of you we will see on Thursday as we're doing another Lunch and Learn then. So thank you. Bye, everybody.
Thank you.
Bye, everybody.